Today we'll be discussing a very interesting topic, and that is edema or pedal edema. Now, pedal edema is extremely common, and in that we can either have pitting edema or non-pitting edema. So, in this topic, we'll be discussing about the pitting edema. So, how do we come to know that this edema is pitting or non-pitting? You simply press on bony surface, and if you can see a pit, then that is a pitting edema. You can see I have pressed two fingers, this is one finger and this is second finger, and I can very nicely see that there is one small pit which is formed. So this is pitting, which is very typical sign of pitting edema. Now second thing, whenever we get edema, we'll see swelling as well. So swelling is very common feature, and the third thing is you can see that there will be some shiny reflection of the skin, which is very commonly seen when the patient has edema. You can see this is all shiny reflection. This is all because of accumulation of the water underlying the skin and subcutaneous tissue. So you can see this shininess which is here as well, but it is not that much prominent because of the exposure. So, how to approach edema? Whenever any patient gets edema, you can see, so you can simply press anywhere, especially wherever there is bone underlying, like this the shin. You can press at ankle, or you can press at this area also, and you can very well see the pitting. So, how do you approach this pitting edema? Pitting edema is very common, and there are some very important reasons which we should always remember. First, I always think of heart disease. In heart disease, we know any patient who has ischemic heart disease or hypertension. Heart disease means the patient may have heart failure with a reduced ejection fraction, or patient may not have heart failure with reduced ejection fraction, but the patient may have ischemic heart disease, or patient may have coronary artery disease. So what is the problem in this ischemic heart disease or hypertension or heart failure with reduced ejection fraction is they have a very bad RAS system, that is renin angiotensin aldosterone system. What does this do is they unnecessarily keep sodium and water as well in the body. So actually, because of this ischemic heart disease or hypertension or heart failure with reduced ejection fraction, body has more tendency of retaining sodium and water. So there is more sodium and water retention, and these patients very commonly present with pedal edema. So pedal edema is one of the most common sign of heart failure. So in such patients blood pressure should be definitely seen. Patients ECG should be seen to see any heart block, to see whether there is poor R wave progression or low voltage ECG, or to see LVH with strain pattern, or to see conduction blocks like LBBB or RBBB. So this type of changes we can see in ECG in any patient who has this pedal edema which is pitting. We should always think of this. This patient must undergo 2D echo to see how much is the ejection fraction of the patient. Is the patient has regional wall motion abnormalities, whether patient has some valvular disorders, like the patient may have MS, MR, or TR, TS, or whether the patient has any patent ductus arteriosus or VST or AST, because those patients also lead to fluid overload and more accumulation of water, and the patient may land up in heart failure and may present with the pedal edema. Apart from that, uh, so whenever we are thinking of heart, the ECG, echo, TMT, and if reduced ejection fraction is there, or if the patient has shortness of breath which is out of the proportion of the symptoms, then definitely angiography should be considered, coronary angiography should be considered. Now second thing which I always think of in any patient who has this pedal edema is whether the patient has any physiological problem like pregnancy. In pregnancy, it is very common to have increased plasma volumes. They very commonly have physiological pedal edema. So in that, you can simply restrict the fluid, and the swelling should simply go away. We can also think of any other and physiological problem like anemia. In anemia also, because of the low hemoglobin, there is excessive renin angiotensin aldosterone system activation. So there is more sodium and water retention to maintain the blood pressure. Because if hemoglobin is less, the pressure of the blood will be less, because blood is all made up of hemoglobin only. Hemoglobin, RBC, WBC, platelets. So major component of the blood is because of the blood, and blood mainly is made up of hemoglobin. So if anemia is there, if hemoglobin is less, so to maintain the blood pressure, the sodium water retention is in excess, so the patient may present with pedal edema. So the first important organ which is important is heart. Second important organ to remember is kidney. We should always think that the patient may have acute kidney injury, patient may have acute renal failure, patient may have CKD, patient may have nephrotic or nephritic syndrome. So these are the things where you can very commonly get bilateral pedal pitting edema. So AKI, the patient will always have some history of fever or infection or admission, or history of ingestion of nephrotoxic drug, which should be ruled out. In acute renal failure, definitely the patient will not at all have any urine output, or the patient may have oliguria. When we call it as oliguria, when the urine output is less than 400 ml per 24 hours, or when we call it as anuria or complete acute renal failure, is urine output of less than 100 ml every 24 hours. So in acute renal failure, the patient may have acidemia. So always ABG or VBG should be considered if you are thinking of acute renal failure. So in acute renal failure, you will have acidemia, which is very common. The patient may have hyperkalemia, which you should always consider. So if the patient has acute renal failure, so that his urine output is completely shut down, all the nephrotoxic drugs should be completely stopped. Creatinine should be done. Usually the creatinine will be always more than 6 milligram per deciliter. The urea may be more than 200, and patient may have uremic encephalopathy. Patient may have markedly reduced appetite, and such patient may need hemodialysis. The second thing is in CKD. CKD is very common. In CKD again, CKD itself stands for chronic kidney disease, means there is chronic inflammation. So there, these patients will definitely have increased creatinine. It will be more than 1.5 milligram per deciliter, and urea may be normal or it may be more than 40. So in these patients, that is the reason why any patient who has pedal edema, renal function test should be done to see the potassium level, to see the creatinine level, to see the sodium levels, because this creatinine, urea will tell you whether the patient may or may not have CKD. To diagnose the CKD, you can do sonography of the abdomen. If the patient's sonography shows a raised corticomedullary junction, if it shows a raised CMD, that is corticomedullary junction, then we call it as CKD. Because in normal kidney, this is the cortex, the outside portion is cortex, and this midline portion is medulla. So normally you can very clear cut see the differentiation between the two, that this is the medullary part and this is the cortical part. But in CKD, it is very difficult to understand where is this uh, demarcation. So in the CKD patients, you'll simply have a uniform echogenicity. So there will not be very clear cut demarcation between medulla and cortex. This is called raised corticomedullary differentiation, or this is called lack of demarcation between cortex and medulla. which simply tells you that the patient has CKD, and the underlying diseases like diabetes, hypertension, alcohol, tobacco, or cancer, or any other pathology like recurrent renal calculi should be sought out. And the patient should be put in CKD staging, which is from 1 to 5, and it is based on the estimated creatinine clearance or estimated glomerular filtration rate. And in nephrotic syndrome or glomerulonephritis, these are very common disorders where the patients will lose lot of proteins in the urine. The patient may also show pus cells in the urine. So these patients may have 3 plus or 2 plus protein loss in the urine. So urine routine is always very important because urine routine will tell us how much protein the patient is losing. If the patient is losing 2 plus or 3 plus proteins in the urine, it highly suggests the nephrotic syndrome. These patients will usually present with anasarca, hypoproteinemia, hypoalbuminemia. So these patients usually respond markedly with diuretics and albumin supplementation, and mostly steroid or other immunosuppressant medicine has to be given to treat this nephrotic syndrome. So we have seen heart, we have seen kidney, we have seen pregnancy, we have seen anemia. The other thing is CLD or chronic liver disease. So any chronic inflammatory disorder like chronic heart failure, ischemic heart disease, chronic kidney disease, then again chronic liver disease. This is very common. Most of the time the patient will be chronic alcoholic or the patient may have some malignancy. So any disease of the liver, like it can be malignancy, it can be alcoholic liver disease, it can be uh, gallbladder CA, it can be HCC, or it can be any malignancy with mets to the liver causing significant liver damage. So whenever there is liver damage, there are two things which occur. The first is the liver mainly synthesizes albumin. So if albumin production is less, then automatically this patient will have bilateral pedal edema. So we should always look for serum albumin levels which must be more than 3.5 gram. If it is less than 3.5 gram, it means ki this patient may have this pedal edema because of the hypoalbuminemia. So in any CLD patient, the patient will have hypoalbuminemia. And second thing is there is again stimulation of renin angiotensin aldosterone system, which again markedly increase the sodium absorption and markedly increase the water absorption. That is the reason why we ask this patient to keep their fluid intake to less than 1.5 liter per day, and we give these patients aldactone so that this RAS system remains inhibited. Aldactone can be given from 50 to 200 milligram per day mostly. More than 200 milligram is not usually used in most of the patients, though it may be used in some of the patients. So CLD must be always for that you again can do sonography of the abdomen. So sonography of the abdomen can tell you the kidney size. So if the patient has CKD, the kidney size will be small or reduced. If the kidney size is normal, if there is no problem in CMD, it means the patient may have AKI and the patient doesn't have CKD. We can see liver whether patient has this cirrhosis or not, because normal liver has smooth outline. Normal liver has smooth outline, but in alcoholic chronic liver disease or in cirrhosis, this smooth margin will be more of a lobulated, or there will be irregular margins of the liver and with caudate lobe hypertrophy. Whenever there is irregular margins with caudate lobe hypertrophy, we call it as CLD, and mostly it will be cirrhosis. So small size of liver, irregular margins, caudate lobe hypertrophy, shrunken liver, this all tells that the patient has cirrhosis, and it then again cause the pedal edema by renin angiotensin aldosterone system activation, and hypoalbuminemia. So these are the diseases. Apart from that, we should always think of diabetes and hypertension, because in diabetes, very commonly the patients will have diabetic nephropathy, which causes CKD, and the CKD nephropathy, proteinuria, loss of protein in the urine, hypoalbuminemia. This is all caused by diabetes mellitus, and this will cause pedal edema. In diabetic mellitus, you can simply do HbA1c, you can see fasting blood sugar, postprandial blood sugar, you can see creatinine, urea, urine albumin, and creatinine ratio, because this is the earliest marker which will tell that the patient has proteinuria, even if all the reports are normal. So if this is more than 30 milligram, it means that the patient is having leakage of the proteins through the urine. So this urine albumin creatinine ratio is done in diabetic patients as well as in hypertensive patients, to see the patient whether has proteinuria or not. Because if the patient has this proteinuria, if it is more than 30 milligram, it means that the patient is progressing slowly to CKD. So in diabetes patients, you can see other features also. Like in patients, the patient may have diabetic neuropathy. The patient may have diabetic skin changes. The patient may have diabetic nail changes. So diabetic neuropathy, there will be pain, there will be tingling, numbness, abnormal sensation, burning sensation of soul. These all symptoms will be present in diabetic neuropathy. Because of neuropathy, because of the damaged nerves, there will be poor autoregulation of the skin of the lower limb. So what you can find is dry skin. See here, this is all a dry skin. You can see the small like boxes which are formed. See the pigmentation, see the pigmentation, see the patches. So this is very typically called diabetic dermopathy. These are all diabetic patches because of the poor blood flow to the skin. So dryness of the skin, loss of luster, dryness, this diabetic patches or hyperpigmentation. See, you cannot see any hair. You are not able to see a single hair on the leg. Even though the patient is around 45 to 50 years of age, there is not even a single hair. Because why? Hairs need good blood flow and good nerve supply. If one of them is compromised, the patient may have hair loss. So there are no hairs at all on the leg, which tells that this patient has the neuropathy. So if there is some disease which has neuropathy, significant neuropathy, that is very commonly seen with pedilema, diabetes is very common. Though neuropathy is seen in almost all the cases, like in CLD, neuropathy is very common, diabetes, neuropathy is common, but in ischemic heart disease, it is not that much common. So diabetes should be always thought of. And the last, the most important disease is hypertension. So in these patients, blood pressure should be checked, ECG should be checked, 2D co should be checked, to see EF. The patient must be told to keep water intake or fluid intake of less than 1.5 liter per day. And such patients, this pedal edema is very well treated by diuretics. Lasix, like 20 milligram to 100 milligram, depending on response. Most of the time, 20 milligram per day, 40 milligram per day is more than sufficient. We can give Ditor, that is torsemide. Again, 5 milligram to up to 30 milligram, 40 milligram is more than sufficient in maximum number of cases to reduce this pedal edema. And total fluid restriction is also very important. The last thing which we should always consider is hypoalbuminemia. Hypoalbuminemia, which is very commonly seen in nephrotic syndrome, where there is a large loss of proteins. There is seen in CKD patients, which is seen in CLD patients, cirrhotic patients, because albumin is synthesized by liver. So if liver is damaged, albumin will not be synthesized, or liver will synthesize the albumin, but this is all lost by kidney disorders, which is seen in nephrotic syndrome and CKD. The fourth thing where hypoalbuminemia is seen is malnourishment. Very commonly, the patient may not get proper time, or they may not have a good appetite at all. So overall, the patient may have stress, alcoholism, bad addiction, poor lifestyle. So they may not take good diet, which may lead to chronic malnourishment, malabsorption, and hypoalbuminemia. So this all things should be sought, and we'll meet again in the next topic, and thank you.